Joint hypermobility versus joint instability. My name is Dr. Ryan Emmons, and I'm going to be walking you through this presentation. So here's the problem. Joint hypermobility and joint instability are not the same. They must be differentiated. The trouble with these two conditions is that there is confusion between them, and they are often lumped into one category or used interchangeably. This is a huge disservice. They can coexist, though one is directly treatable and one is not. So, what is joint hypermobility? Joint hypermobility means that a person's joints have a greater range of motion than is expected or normal, and this is according to the Ehlers-Danlos Society at ellersdanlos.com. Something that's interesting is the joints can be stable in neutral with hypermobility, and it can exist with or without joint instability. If we look at what is joint instability occurs when a joint has lost its structural integrity due to ligament laxity. The joint can be unstable at neutral, and it can exist with or without hypermobility. The Ehlers-Danlos Society indicates that they are two separate issues. So if we look at the Ehlers-Danlos Society website, we can see this highlighted area. The problem, it says, when it comes to hypermobility, the problem occurs when joints are not just hypermobile, but also unstable. Joint instability occurs when the bones of a joint aren't held in place securely, as I had mentioned with the definition. This can lead to joint subluxations, dislocations, sprains, and other injuries. Again, we are talking about two separate issues, joint hypermobility and joint instability. Joint instability can cause both acute and chronic pain and interfere with daily life. Better accuracy means better results. So every day in my clinic, treatment success comes from a complete assessment, diagnosis, and treatment. The more precise and accurate the diagnosis and understanding of the ailment that I see, the better treatment results I can achieve. If I say it's a neck strain, generically, then it will yield a fair response. If I say it is a cervical spine joint capsule sprain, much more specific, it yields a great response. So the more detailed the understanding, the better treatment is applied. And the same goes for joint hypermobility and joint instability. So let's get into the cause. So when we look at the cause of hypermobility, the underlying root cause of generalized joint hypermobility is not clearly known, though some thoughts are that it's a combination of multiple factors such as genetics, connective tissue composition, and biomechanics. So I pose this. If we don't know the exact mechanism, how can we treat it and manage it accurately? Because when we look at the cause of joint instability, over the past decade, I have been treating joint instability. I have treated it with excellent success. My success is based on discovering the three, not one, three major sources of ligament laxity and addressing each specifically when necessary. In my experience, a lack of success from instability treatment means not all three were managed or the order was not followed. If we know the mechanism, the exact mechanism, then we can treat it and manage it accurately. This makes joint instability highly treatable. So, something to keep in mind. Being flexible, bendy, double jointed is not usually a problem. And for some, like dancers or gymnasts, it can even be an advantage. Hypermobility that does not cause pain or other symptoms is referred to as asymptomatic joint hypermobility and does not need to be treated. And that is according to the Ehlers-Danlos Society website that I mentioned earlier. Therefore, just because someone has hypermobile joints, it does not mean that there is pain or symptoms. So then, why the symptoms with hypermobility? Because if symptoms exist, then the symptoms must tell a clear story, right? Joint hypermobility symptoms should help clear a path forward. Joint instability symptoms should help create a plan. This would help us to differentiate them, wouldn't they? But when we're looking at a comparison of the symptoms, we see big similarities. So then, if joint hypermobility and joint instability have a lot of symptoms, then let's go a little bit deeper. So, what about HSD or uh, hypermobility spectrum disorder? So, HSD, the hypermobility spectrum disorder, occurs when a person has symptomatic joint hypermobility that cannot be explained by other conditions. A person with HSD may have joint instability as their only concern. Think about that. Or may have other medical issues as well. Two different people with HSD may experience very different symptoms. For example, one person with HSD may have severe joint instability, fatigue, and autonomic dysfunction. Another person with HSD may have mild joint instability and severe headaches and GI issues. Both people experience HSD differently, but neither person has more HSD than the other. The cause is still undetermined. But I want you to think about those symptoms that I just listed. So, one person can have joint instability, fatigue, and autonomic dysfunction. Well, that sounds familiar. So, when we look at HSD, we can look at different types. Not everybody is going to experience it the same. For some, hands and the feet, some throughout the body. So there is variability. And when we look along the spectrum, we can see on the right that there is a list of symptoms. And of course, people can experience them differently. But now here's where we have to get a little bit deeper. We keep looking and seeing joint instability, but do those symptoms not look like symptoms related to a condition of joint instability? Oh, and yes, they do. So we see a lot of symptom overlap. And this is where we keep talking about, and I keep talking about the fact that we need to distinguish the two so that things become treatable. So what about HEDS? So hypermobile EDS, a much more serious condition. So hypermobile Ehlers-Danlos syndrome is a heritable connective tissue disorder that causes generalized joint hypermobility, joint instability, and chronic pain. HEDS is also associated with a variety of other symptoms and related conditions that affect many different areas of the body. HEDS is the most common type of EDS, accounting for about 90% of EDS cases. And of course, the content that I speak of still comes from the Ehlers-Danlos Society themselves. The cause is currently undetermined, though they are looking into sources and making headway every day. But again, we look at common symptoms and we see a huge similarity. And it's not to say that joint instability causes EDS. My point here is that there's just so much overlap. What about the neurological symptoms? This is a very important consideration. I see neurological symptoms in many cases of spinal joint instability, most notably in upper cervical instability. And that is because of neurological interference. So, an interesting question is, can joint hypermobility cause these neurological symptoms? I'm sure it is possible, but by what mechanism? When we talk about assessment of hypermobility, for assessment, we are speaking in terms of assessing generalized joint hypermobility. But this can apply to the other types such as HSD or HEDS. It's a great baseline. It is common to use the Baton score, a physical testing method used as a screening tool for hypermobility. According to the Ehlers-Danlos Society, the Baton score is a good screening tool for the likely presence of generalized joint hypermobility. However, people often have hypermobility in joints not measured by the Baton score, such as jaw, neck, shoulders, wrists, hips, ankles, feet, and toes. In these situations, only relying on the Baton score is not enough, and that is fair. So this is just the test, and you can find this online where there's going to be 5 tests and it's going to be under a scoring. And I have used that with patients just as a general screen, and I think it's very valuable. Now let's talk about an assessment of joint instability. Joint instability simply comes from a lack of sustainability of joint alignment due to ligament laxity. From a spinal standpoint, we often use neurological testing to evaluate nerve function due to spine joint dysfunction. This clinical evaluation is very effective and it's what I use every day. We can use imaging, and a lot of people online will push the use for imaging, but this is not always necessary, as I have indicated in my previous video on upper cervical instability, and it's not accessible for everybody to get, and we don't want to limit the access to getting joint instability treated. So consider this. I have heard hypermobile influencers say they do not like current testing because some do not test well in this hypermobility evaluation, and that's fair. We know that not everyone can have hypermobile joints all the same, but hypermobility is one of the top 3 symptoms in hypermobile conditions. So, if someone does not have traditional hypermobility, then is it not just joint instability? Or a combination of both, considering that joint instability is a condition on its own for people that do not have hypermobility. Moreover, there can be a ratio. Just as I speak on C1 misalignments and concussions where symptoms overlap and the ratios can be vastly different, the same goes for hypermobility and instability. There can be a ratio of involvement and contribution of symptoms in this manner, 10% instability and 90% hypermobility. Sometimes it can be a 50-50 ratio. And even so much as, say, 90% it is instability related and only 10% related to the hypermobility. This is never to take away from anybody's experience with hypermobility. I know it's serious for people that deal with hypermobility issues, but instead to give a perspective and a solution to treatment. And that, for me, is really important. So let's go over some interesting facts. Every case of symptomatic joint hypermobility that I have seen in the office has had joint instability. Every case. And by treating the joint instability, I have helped each and every case in terms of pain, strength, function, and symptoms. More, every case of HSD and HEDS that I have cared for in the clinic had a primary cause of ligament laxity that was not the HSD or HEDS. Okay, that is not to say that a hypermobility condition cannot be a contributor to any of the ligament laxity. I'm not saying that because, again, on the last screen, I said that there can be a ratio. But what I am saying is that it was not the primary source in my clinical experience. Just because we can attribute ligament laxity to conditions that follow a narrative does not make it accurate or correct or treatable. Again, this is exactly why I stress that it is important to clearly understand and differentiate both the conditions, joint hypermobility and joint instability. We lose out without differentiation between the two, to the extent that one of the most important and relevant published papers I have seen in this area used the term hypermobility and not instability and was not found for the actual benefit that it should have achieved. It came across my desk, and with the right application, it provided an immense breakthrough in treating joint instability, which we have achieved in the office. So let's get into treatment. Treatment of hypermobility. Because we don't know the exact cause, how do we treat it? Many influencers, specialists, and researchers like to prescribe bracing and exercises. They are great adjunctively. But as with joint instability, if there is symptomatic joint hypermobility, then there is highly likely spinal joint dysfunction and therefore nerve involvement. We're talking about both these conditions. If there is nerve involvement, then the muscles are inhibited. It is a signal problem, not a muscle problem, maybe a muscle symptom, but the muscle has a signal problem, and that means that we call it inhibited. Exercise cannot fix inhibition, which I discussed in a previous video. This becomes a huge disservice because people are then typically managing at best. Why not treat the joint instability? It is the most obvious and effective place to start. In terms of treatment of joint instability, because we know the root cause and the three major sources of ligament laxity, we can treat this condition. We can identify which is the primary source and treat accordingly. Want to know these three sources? I'm going to go over these in detail in future videos. It is much too much to cover today. So be sure to subscribe so you don't miss out. Or you can check out my joint instability courses that explain this in detail at courses.clinicalupgrade.ca. For the sake of this conversation, joint instability is treatable. So, what is my motive? My motive is to teach courses to practitioners to better understand joint instability. Patients deserve a higher standard of care. My goal here is education to give you awareness and information to ask questions. Don't settle for the current standard. So then you may ask, okay, then what next? Being aware of and understanding joint hypermobility is very, very important. But we want to be aware of any and all types of care available, not just exercise programs by influencers that you see online. Though they are often great exercises, and I appreciate all the work that they do, but it is not the only source and the only avenue for assistance. Because what happens then is this tends to develop a bit of a dead end for many and an echo chamber of conversations. People get lost. And it's all great that we find a community and we can have conversations about the challenges we face, but ultimately you still get stuck. And to get out of that, we need a solution. I am an action-oriented practitioner. And I do my best to provide as many therapeutic solutions to my patients as possible. Exercise exercises are important, of course. I'm a natural bodybuilder, but it's only one small piece to the big puzzle and not the first solution, which is stability and neurological function. Nerves feed muscles. We need to look at those nerves that are feeding the muscles you are trying to exercise. It is often the case where it is the nerves and the ligaments that are problematic, but we have such a tendency to focus on the muscles and the joints, which I don't agree with. I believe that looking at the nerves first, which is always the first in order of how I deal with things, and of course looking at the ligaments, because if there's ligament laxity, the muscles are going to be reactive. Okay. This is why collaboration is necessary between professionals that are versed in hypermobility, instability, and exercise. A collaborative approach is definitely best for the patient. Isn't that what we're focused on? Isn't it about getting people better? Not about what program somebody has to sell, but isn't it about actually creating a solution and getting somebody better and improving their quality of life? Yes. For your well-being and quality of life, I strongly recommend you get your joint instability assessed and treated. It can be life-changing and make a dramatic difference. You do not need to struggle. If I ruffled some feathers today, I'm glad. We need to change the trajectory of care with both joint instability and joint hypermobility. It starts with challenging the narrative and current standard of care. Thank you all for joining. I hope this was clear. It's never to say anything that is negative about hypermobility, but I want to give you new solutions, things that you maybe haven't tried, and there's a lot that can be accomplished. I wish you all the best.